investigations and therapeutic. We divided into presumed and confirmatory ocular tuberculosis according to these things. Most common is uveitis, and now I come to a rare manifestation of ocular tuberculosis case. We had a 30-year-old lady who presented with pain and redness in a right eye for past 3 months, and it was the painful red mass was gradually increasing in right eye for 2 months. She had watering and diminution of vision as well. It's yeah. This was the nodular scleritis patch or nodular scleritis lesion seen in her right eye nasally. It was raised, firm, tender, lobulated, immobile scleral mass, approximately 12 to 10 millimeter in diameter. Yeah. She didn't give any history of surgery or any trauma. Vision was 624 in right eye. She had anterior chamber and retrolenticular cells and flare. This was the picture of posterior segment, which showed multiple lesions, subretinal lesions, yellowish lesions, which were elevated, and the largest was approximately 3 disc diameter. The similar lesions were there in the left eye as well. General physical examinations showed most of the things were normal. So we made the diagnosis of nodular scleritis or scleral abscess with anterior uveitis with multiple choroidal granulomas in both the eyes, most likely tubercular in origin. We did UBM, which showed bulge sclerochoroid with central scleral hypoechogenicity. But the differentials were many at that time. To zero down to the diagnosis, we went to the history because history plays an important role when you don't have a absolute diagnosis here. She had an history of intermittent fever and cough in first trimester of her pregnancy 1 year ago. Was suspected as a case of tuberculosis but refused treatment till childbirth. Antitubercular treatment was advised postpartum, but she was non-compliant. She was hospitalized elsewhere for high-grade fever and productive cough. The medical history record showed she had Monto of 15 millimeter. Along with that, sputum was negative. She was advised ADT at that time according to her weight. And X-ray also showed multiple miliary mottling. This was her old record. We did the investigations showed ESR of 31 millimeter. Rest was negative. So now we made confirmatory diagnosis of tubercular nodular scleritis with anterior uveitis in right eye and choroidal tuberculomas in both the eyes. We prescribed her ADT, 4-drug regime according to her weight, added prednisolone 30 milligram and ranitidine along with calcium. Topical steroids were given along with hometropin. So this was the result after 4 weeks. The vision improved to 6 parts from 624. The cells in flare decreased. The size of the lesion also decreased. It started showing pigmentation that meant thinning of the sclera as the posterior uveal tissues started showing up. But the important was that choroidal lesions, they started flattening and started showing pigmentation around. At this stage, we performed fluorescein angiography to see whether there is any activity remaining in the lesions, but we didn't see any increase in the size, only the intensity of fluorescein increased. That showed the lesions are healing. These were in the right eye as well. Now, after 2 months, this was the picture. The lesion was almost totally healed with thinning in the center. The vision was 6 parts. Rest, everything was normal, and the pain had also markedly reduced. So, take home message I would like to say that proper history is really important in clinching the diagnosis, and it prevents advising unnecessary tests as well. Therapeutic trial of ATT can be a big tool in confirming the diagnosis. Most important, hit early and hit hard. Systemic steroids should not be delayed. Thank you so much. Thank you, ma'am.
Thank you, Garima. Excellent case. So one question that everyone always wants to ask is, how do you diagnose tuberculosis? We know that the diagnosis is still presumptive, but in your, in your mind, what are the features that you would think, or what are the tests you would order to
The
confirm
most,
tuberculosis?
see, as I mentioned, according for the classification, it depends upon the clinical evidence, it depends upon the symptoms itself, it depends upon the test what we do. we have divided them into presumed tuberculosis and confirmatory diagnosis. I would like to go back to the presentation once. I want to show the slide also. Excuse me. Hello. Can I get the presentation back, please? Yeah. No, the previous. Yeah. So the confirmatory diagnosis, if we find the evidence of tuberculous bacilli, if it is pulmonary, if we get sputum positive, which is really hard because it needs at least 10,000 of the bacteria to be visible over there to become positive. So generally that comes negative, but if we find that, it becomes confirmatory. And then clinically we see these signs from A to F, any one of these signs along with ocular investigations positive, then we find it confirmatory. Among the ocular investigations, can you see it right? Among the ocular investigations, AFB culture from ocular fluids like AC tab or vitreous biopsy, but vitreous biopsy done with a cutter in a proper settings, especially in young eyes, and if we have positive PCR, then it becomes confirmatory. If we don't have B over here, but we have clinical signs of uveitis, then but we have say positive MON2 test, or we have evidence of healed or active lesions in the choroid, or we have healed or active lesions in radiography, then we term it as presumed ocular tuberculosis. Or even if we have therapeutic tests like we gave the ATT and the patient responded very well, then definitely it would be tuberculosis. Now,
Yeah, thank you. So most of the time, even in spite of all these tests, it's our clinical judgment that we use to diagnose tuberculosis. To add, Dr. Pavla?
thank you.
So thank you, Garima.
Thank you so much.
Thing about the ATT, since you asked for it, is important. Like with the extended regimen, we are getting ethambutol in the longer duration, and we see quite a bit of ethambutol-induced optic neuropathy. So in these situations, we can request the pulmonologist to modify the treatment therapy, ethambutol for 2 months, and then in the extended regimen, INH and rifampicin alone are sufficient enough to control than giving the ethambutol up to 7 or 9 months. So that one thing I would like you to take precautions when you are giving anti-TB drugs.
The other thing is to order a CT scan of the chest, because the X-ray doesn't pick up lesions. There have been so many cases where the X-ray is negative, doesn't show any lymph nodes. But when you order a high-resolution CT scan, you see those typical mediastinal lymphadenopathy. So X-ray, to my mind, doesn't really pick up tubercular symptoms, and we do order a CT scan.